Our first speaker today will be Dr. Chen, who you just heard from. Dr. Chen is a professor of neuro-ophthalmology, and he's really so well respected in the neuro-ophthalmology community. Firstly, because he's just a very nice guy, and everyone gets on with him, so that's always a good thing. But just a great doctor and so dedicated to his patients. As many of you know, if you send him a message, Dr. Chen will be super fast to get back and help out, and he helps me out in the clinic when we see a MOG patient and I say, John, can you squeeze this patient in, and vice versa. We really try to work together as a team, and we have many others who help us out at the Mayo Clinic, but it's been real spectacular to have John here, and he's pioneering much of the research around the eyes, and the eyes are so important in MOGAD. So we'll be interested to hear more about how MOGAD affects the eyes. So welcome, Dr. Chen.
Well, thanks so much, Owen. You know, at Mayo, it's wonderful. So the ophthalmology department is on the 7th floor of the Mayo building, and then one floor up is Owen Flanagan, the neurology department. So we just have patients, actually see us both. Anyone who has MOGAD, whether they have eye complaints or not, they see us both here at the Mayo, and it's really a lot of fun working with Owen. So we thought we'd kick off the summit in terms of the science part about how MOGAD affects the eyes. And that's because MOGAD most commonly presents with optic neuritis. And so again, in terms of optic neuritis, it's an inflammation of the optic nerve. And if you have MOGAD, there's a good chance you may have had optic neuritis. And if your presenting symptom was an optic neuritis, if you were to have a relapse, there's about an 80 to 90% chance that relapse is going to be optic neuritis. So even if you haven't had optic neuritis, I thought we could step through how MOGAD presents with optic neuritis and we'll talk a little bit more about treatment later. But essentially, optic neuritis is that inflammation of the optic nerve. And unlike multiple sclerosis, which is actually a more common cause of optic neuritis, with MOGAD, it tends to hit both eyes at the same time, not just one eye. But if you've got bilateral optic neuritis, MOGAD should be really high on the list. Another thing is, as when we look at the eye and we look at that optic nerve, with MOGAD, oftentimes the optic nerves are very swollen. And so you can see these pictures here. This is a picture of both eyes being involved with a super swollen optic nerve. And we don't typically see that with multiple sclerosis optic neuritis, but we definitely see that with MOGAD. So these are some features that we look for. Another feature we look for when an ophthalmologist or neurologist is seeing a patient with optic neuritis, they're going to make us think about MOGAD, is they get profound inflammation on the MRI. I don't have a pointer, but you can see these little red arrows, and essentially the optic nerve on an MRI should actually be gray, not white. And all that white you see on that MRI scan, that's all inflammation. And so what you can see is essentially the entire optic nerve is on fire. And that's what MOGAD does. It causes a lot of inflammation of the optic nerves. And again, with MS, you'll get inflammation, but you'll see a small segment of the optic nerve involved. With MOGAD, a ton of inflammation. And again, because of that inflammation, we get the eye pain, we get the vision loss. And so patients with MOGAD tend to have a lot of pain. 90% of patients have pain, and the classic feature is it's often worse when you move your eyes around. And so that's a feature you're looking for MOGAD optic neuritis, pain with eye movements. And then the vision tends to drop, and usually it's that first attack where you don't know what's going on that the vision tends to drop and drop and drop. Because later on, if you have MOGAD and then you start having eye pain and blurry vision, you're getting steroids right away. But that first attack, it really takes a long time to figure out what's going on. And the vision can drop for about a week. Sometimes I even heard patients dropping for even 2 weeks. And without treatment, early on treatment, the vision tends to drop really, really bad. And I'm sure anyone who had optic neuritis in this group, oftentimes the vision is so bad where all you can do is count fingers or see movement. There's some patients who can't even see light when it gets that bad. But the good part is the majority of optic neuritis recovers with steroids. And so we'll talk about treatment more later, but essentially if you have optic neuritis or any MOGAD attack, you're going to want to get steroids as soon as possible. And when you go to the eye doctor, they're going to check visual acuity. And I thought I would just step through visual acuity because we all hear 20/20, 2200. But really, what does that exactly mean? And so what 20/20 means, that's actually normal vision. That means at 20 feet, that's what a normal person sees at 20 feet. So everyone, 20/20 is perfect. Well, what does 2100 mean? What 2100 means, what a normal person sees at 20 feet, or at 100 feet, if I were to step back 100 feet away and then take a look, that's what a MOGAD person sees at 20 feet. So essentially the bottom number, the bigger the number, the worse it is. So again, if you're 20/20, that's perfect. If you're 2200, again, that means what a normal person sees at 200 feet, that's what a patient with MOG optic neuritis sees at 20 feet. That's actually considered legally blind. And so that's what these numbers mean when we're checking you on the chart and we're saying, today you're 20/40 or today you're 20/20. That's what we're talking about. And again, a patient with, and that's the MOGAD affected eye. Again, it's just much more defected if the vision is an issue. And so when it comes to optic neuritis, we've got three main causes of optic neuritis that we know about. We have multiple sclerosis, this other condition called NMO, and then there's, of course, MOGAD. And in terms of how the vision loss gets affected, with MOGAD, they come in with very, very bad vision. They, again, often almost completely blind by the time we see them. But fortunately, with steroids, the majority of patients recover, but not everyone. So you can see here the legal blindness is 2,200, and for MOGAD, 5% end up legally blind. But if you compare that to NMO, it's 33%. So it can be a blind disease, but usually if you treat with steroids, they do pretty well. The other number that's important for patients to know is 20/40, and that's important because that's your ability to drive without restrictions. And you can see the numbers here. With NMO, only 40% of the patients end up 20/40 or better. With MOG, it's 91%. But again, still patients can have permanent vision loss. And so that's what we typically see in terms of the visual acuity charts. But there's a lot of visual sequelae from optic neuritis. So we talk about decreased vision. That's what we're checking on the chart. And again, we talked about how a lot of patients recover back to 20/20. But my patients, even when they get back to 20/20, they say, well, doctor, why can't I see? I'm 20/20 on the chart. Why can't I see? And there's a lot of different reasons why. So one is visual fields. So you could actually be 20/20, but if you're missing half of your vision, that's going to be a big issue for patients. And so on the right here, we've got a normal visual field, and on the left, we've got all that's black. That black is where a patient's not seeing, and yet they're 20/20, but if you're missing half your vision, that's going to be an issue. So that's an explanation for why patients might not be able to see so well. But we have some patients who are 20/20, and they've got normal visual fields, and they still can't see well. And they're like, well, what's going on here? And that's because after optic neuritis, even though you recover back to 20/20 on a normal chart, a lot of patients will have decreased contrast. And here's just some images of kind of what a normal image should look like and patients with worsening contrast acuity. And we can actually measure that with a low visual acuity chart. The top chart is your normal chart, and you could be 20/20 normal vision. But on the bottom chart, you might not be able to make out those faded lines as well. And so that's really, really common after optic neuritis. In fact, vast majority of patients after optic neuritis, even when they're 20/20, they've got decreased contrast. So essentially, when the lighting's not as good or there's a lot of glare, their vision's just not going to be as good. And that's really, really common. And so, again, I would say 95% of patients with optic neuritis have decreased contrast, even if they're 20/20. Another thing that patients might notice is this thing called UTOS phenomenon. And I'm sure many of you in the room have noticed this, but essentially when patients get hot or they do a lot of exercise, a lot of the symptoms from MOGAD and DMARD disease will kind of flare up. And so if you had optic neuritis, if you get in a hot tub or in a sauna, you'll realize that the vision actually gets blurry while you're hot. And that's called UTOS phenomenon. And that's thought to be because the signal from the eyeball to the brain, that speed of transmission is just a little bit slower when you're hot or when you're doing exercise. The one most important thing that I want to point out is that is not permanently damaging the optic nerve. That's just while you're hot, that signal is going slower. But once you cool off, you'll be fine. That's not a sign of optic neuritis. It's just a sequelae from it. And so that's important. And this last thing called Pulfic phenomenon I thought I could talk about. So essentially, if you have optic neuritis in one eye, what's interesting is the signal from that eye is going to be slow going down to the brain, but the other eye is going quick. And then so it actually throws a little bit of asymmetry in the signal going from your eyes to your brain. And what ends up happening is that you can measure this. If you've got a pendulum that's kind of swinging back and forth, if you have normal eyes, it's going to look perfectly straight. But if you've got optic neuritis in one eye or asymmetric optic neuritis, you'll actually see, instead of it looking like this, a straight line, it'll actually start going a little bit circular. And that plays into role in that patients will often have problems with movement and perception of movements after optic neuritis. Even if they're 20/20, they'll notice some of this slow transmission. And so again, these are all these visual sequelae you can get from optic neuritis that, we might not talk about that much in the eye clinic. We might just say, oh, you're 20/20 with full visual fields. But again, patients are always telling me, well, how come I can't see that well? And then these are all the reasons. There's a lot of reasons why that vision's not as good as it once was. So just wanted to do a quick recap before we switch to the next subject. But MOGAD, again, most commonly presents with optic neuritis. Majority of the patients improve, but about 5% can actually end up legally blind from these optic neuritis attacks from MOGAD. And even if we do say you're 20/20 with full visual fields, there's reasons why patients still struggle with their vision. So happy to answer any questions over the next few minutes. Any questions? Yes. Andrew?
My first relapse, optic neuritis, completely blinded my left eye. So they sent an ophthalmologist to check my optic nerve, and they said my optic nerve was inflamed. And then they put me into the hospital setting, and they gave me 1 gram of IVSM and then a few days of prednisone. Well, that didn't work. Then it went to my right eye, and I'm completely blind in that eye too. And then they finally started doing plasmapheresis, and I was able to get some sight back in my right eye. I got to 20/50. But because they didn't know what disease I had, they didn't know how to control it. And I kept relapsing for 5 years, and I'm completely blind now.
Yeah, it's, Andrea, that's we wish we knew the disease better. When you're first diagnosed, I think it was in 2013, and you probably had the disease even before then. Again, now that we're getting a better understanding of the disease, we now know the importance of early steroids. We now know the importance of possibly using plasma exchange if there's no recovery. Before, all of this understanding of NMO and MOG, there was actually a landmark clinical trial called the Optic Neuritis Treatment Trial. This was published in 1992. And what's interesting about it is it showed that high-dose IV steroids leads to faster recovery, but didn't actually change the ultimate outcome. But what we found out is those patients were mostly multiple sclerosis. There was almost no MOG patients, and there were almost no NMO patients. And we now know that NMO and MOG patients do benefit from early steroids. So really, there's been a large paradigm shift over the past maybe 10 years where essentially if a patient has optic neuritis and poor vision, they essentially have to get steroids right away to try and recover that vision. Very different from what we learned from the optic neuritis treatment trial. And so that's been a shift. Medicine's constantly evolving. And in terms of relapse prevention, again, before we knew what MOGAD was, patients would relapse, but we didn't know what it was, and it was idiopathic. And when a disease is idiopathic, that means we don't know what causes it. And if we don't know what causes it, we don't know the best treatments. And that's why, or especially early on, we didn't have good treatments for patients. And in fact, even when we first started knowing about MOGAD and we knew the disease, we used some of the old NMO drugs like rituximab we thought was the best treatment initially, but now we're finding that rituximab is a very good treatment for NMO, but doesn't work that well for MOGAD. So even our treatments that we're doing to prevent attacks is changing. And of course, we have ongoing randomized clinical trials, which you'll hear about later today, which hopefully will give us FDA-approved medications for relapses. But Andrea, I wish we could turn back the clock. If you were diagnosed in 2023 as opposed to 2010, it would be very, very different in terms of how we approached your case. But again, we're learning as fast as we can. We're learning from the patients here. We're learning from scientists around the world. And again, the knowledge we gain, we're also trying to disseminate to all the physicians as much as we can to try and give best patients treatments for our patients.
I was initially diagnosed with chronically relapsing optic neuritis.
That's absolutely true. So before we knew about MOG, and this diagnosis still exists, it's called chronic relapsing inflammatory optic neuropathy. By definition, that just means it's an optic neuritis that's steroid responsive but steroid dependent, but we don't know the cause. We now know that MOG explains 50% of cryon. And so a lot of those patients with recurrent optic neuritis, essentially it was MOGAD all along, we just didn't know. But it also means that 50% of cryon, we still don't have a biomarker for. There are other antibodies out there that we don't know yet, and we just have to do our best to try and treat those patients. Yes.
So why the optic nerve and not your ears, your sense of taste, whatever?
That's a good question. So why the optic nerves? We don't know exactly why the optic nerves, why the taste and some of these other ones, the ears, it tends to affect the central nervous system. So that would be eyes, brain, or spinal cord. Whereas like the ears is going to be more of a peripheral nerve. And so some of those other nerves don't get affected nearly as much or if at all. But now in terms of optic nerve, brain, or spinal cord, why the nerve so much more, we're not entirely sure why that is. It maybe just have to do with the blood-brain barrier and somehow antibodies getting to that specific area a little bit more. But that's a good question. We're not entirely sure.
Hi. So I was diagnosed 1 year ago last week. Spent a 2 months in a coma. And are there any other eye issues aside from optic neuritis with MOGAD? Because I woke up with pretty significant eye changes, the things listed, but now I've got blind spots in both eyes, and as of a couple weeks ago, a new different kind of blind spot. And I can no longer read fine print because they're central to the vision. And are there other things that present with MOGAD besides the inflammation?
That's a good question. So again, if you were in a coma, you probably had ADEM or corticoencephalitis. You had a diffuse inflammation in the brain. And when that happens, sometimes patients will have optic neuritis, but they actually don't know they had optic neuritis because obviously if you're in a coma, there's a lot of other things, escalating care, trying to get that. So it's very possible you could have had optic neuritis and just not even known about it. That's one thing. Other ways, there are reports of possibly it causing some retinal changes, but again, usually it's going to be optic neuritis, and then any of the retinal changes are secondary to the optic neuritis. One other way it can present is it can cause inflammation in the brain and cause double vision. So essentially you're seeing two of things because your eyes aren't pointing in the right direction. That's not inflammation in the optic nerve, that's inflammation in the brain stem and the nerves that control the eyes, but that can certainly happen. The good part is that tends to recover over time, and if it doesn't, we can use prism to fix it, or you can even do eye muscle surgery to realign the eyes. So again, that is a concern, but more fixable, whereas the optic neuritis part, the frustrating part is we don't have a way of regenerating the optic nerve, so that really comes to the top of the list when it comes to nerves and vision. All right, it looks like we only have time for one more question, but in addition, in the afternoon, we have, I think, a large session on just purely question and answer on optic neuritis, and actually all the various topics you're going to hear about. So we'll just do one more question, and then, again, we'll answer tons of questions in the Q&A later.
So typically, I know that a true relapse of optic neuritis is symptoms that last 24 to 48 hours. If you are experiencing the 24 to 48 hour symptom time period, can it still take some time for it to show up on the MRI if you have an MRI immediately, say after that 48-hour mark?
Yeah, that's a really good question. So really the question is it a true attack or a pseudo attack? And that's important because that's going to change how we're going to treat you both acutely and chronically. And it gets really, really difficult. It really does. Because again, if you've had optic neuritis in one eye, you're going to have a lot of fluctuation in vision. A lot of times for some reason, patients have intermittent eye pain. So trying to tease that out. And there can be delays in terms of how it's going to show up on MRI, how it's going to show up on the pictures of the eyes. There can be that delay. So in that case, usually the first time a patient has these symptoms, I just go ahead and treat them and just assume that's the case. and then look for the MRI, look for the OCT, and let's say I don't find any findings. Then the second time they have the symptoms, then I just kind of wait and see what it's going to do. Is it just going to go away, or is it going to transition? And of course, if it transitions, we treat them right then. So that's kind of how we do it. Usually the first time around, I'm just like, benefit of the doubt, let's just treat. And if it just keeps happening, then we wait and see, can we capture, is it true attack? Because that's very important in terms of what we do moving forward. But Dr. Psych Mazurek is actually going to be talking about, actually in one of her talks, attack versus pseudo attack, and she'll get into some of more of those details. All right, thanks. We'll definitely have many more time for questions later today.